Okay, we're going to go ahead and get started. Our first speaker is a physician scientist, Dr. Alik Widge, and he's also has given TED Talks on his work. He's a brain engineer, and so by a physician scientist, I mean he's has an MD, PhD degree. That's the program that Yoji Shimizu was talking about earlier, where you can get a combined degree. So with that, I will stop and let Alik tell you about his work.
Sounds good. All right, so I just hit present from beginning and should work, right?
Yes.
Awesome. Perfect.
here's the-
Thank you very much. So yeah, I'm going to take about 10 minutes to tell you what has been my life's work for at least the past 10, 15 years, which is this idea of can we actually engineer the brain to treat mental disorders? So I was pretty sure even from high school that I was going to go into medicine, but it really was in college that I got captivated by this idea that we can use computational and engineering principles to understand the brain and fix it when it doesn't work. And more or less, I've been working on that in some form or another ever since. And I came to Minnesota about 3 years ago because, as I'll tell you in about 30 seconds, a lot of my work involves the same kind of implantable medical devices you're going to hear about from our industry speakers later this afternoon. And if you want to work with that stuff, there is no better place than this state. So I'm going to take a few moments to tell you a bit about why is it that I chose to work on mental disorders, and then talk a bit about this idea that by subtly manipulating the brain's electrical activity, we could have a totally new approach, one that's way more specific and we think way more effective to treating those disorders. And to start with, why? Honestly, your generation understands this better than mine did, because this is the single largest epidemic in America. Forget the virus, forget the opioid epidemic. The real epidemic, the single largest driver of healthcare spending in the U.S. is mental disorders. And not only that, it's the single largest cause of disability worldwide. Why? Because it hits people right at your age to about 5 to 10 years from where you are right now, in those sort of high school to early adulthood years. It doesn't exactly kill you, but these diseases, whether it's trauma, whether addiction we include under this, whether it's depression, they just drag on you like a weight around your neck for the rest of your life. And this is a huge problem. This implies that we're spending tons of money every year without getting great outcomes. So what do I mean by not getting good enough outcomes? Well, I don't want to be totally doom and gloom here, right? The treatment does work. This is why we tell people, go get help if you need to. If you need to be on medication, be on medication. Go see a therapist. Because the fact is, for almost half of people, that does work to treat the initial crisis, to treat the initial episode. The problem is the long game. Because number one, it works, it treats, it reduces symptoms, but our current approaches, which is basically medications and talk therapy, usually leave people with residual symptoms. Over time, they wear off. And most of all, it takes a long time. And we're talking a year to 2 years till the first time you find a treatment that actually really works for someone. And then every relapse, you have to go through and play that game again. And this is incredibly frustrating for patients, for their family, for clinicians. So why is this? Why do these strategies, even though they work, not work well enough? And the answer is because they're based around either the idea that mental disorders are just a global chemical imbalance. Your brain doesn't have enough of this chemical. Serotonin, dopamine, norepinephrine. We just need to tweak the balance a little bit. It's like adding a little more pepper to the soup. Or they're based on psychological theory that, okay, if we just sort of work through and you learn new strategies, that'll help you. But we know something. Neuroscience, like what you're going to hear about, but also from my two colleagues who follow, is increasingly telling us that what these disorders are, they're not chemical imbalances, they're information imbalances. That your brain, all these diagrams mean the same thing. Don't try to understand the acronyms. They're just randomly picked out of papers. Your brain is not a single organ. It's a bunch of smaller subparts that need to communicate. And what we think is happening when someone can't get away from a traumatic memory, when someone is driven by a craving for a substance, when they are just feeling crushed by negative emotion and just can't even get out of bed in the morning, that is a breakdown in the information flow in one or more of these networks. And so the question is, what could we do to do better? Instead of, okay, I'm going to try and engage sort of your higher mental functions and change these indirectly by trying to talk with you and strategize with you, or instead of, I'm just going to flood the whole thing with a single molecule and hope that maybe that's kind of like smacking a broken piece of electronics, that maybe it'll just knock whatever was a little bit of a bad connection, maybe it'll knock it back into place. Could we be more precise? And the answer is yes, we could. I'm going to skip over some non-invasive approaches just because of time, but know they exist. And I'm going to go straight to what I work on, which is a surgical or invasive approach. Namely, a set of technologies called deep brain stimulators that are basically pacemakers, except instead of in the heart, you're putting a small wire into the center of the brain. And this is definitely something that we currently are doing only in severe cases that are otherwise resistant to treatments, but it's an opportunity to learn a ton and get more precise, because what it lets us do is at the end of that tiny wire, there's 4 little, like 1 millimeter across electrodes that let us directly access a single small brain area or a single individual connection within those networks I just showed you. And so we don't have to flood the brain with a chemical. We don't have to be indirect. We can go right to where we think the problem is and try to change it. Now, that's great, and this technology exists because it works really well in Parkinson's disease. In mental disorders, and especially most of the studies have been in depression, we're still figuring out what we're doing. Quite frankly, one of the things we found, and this is a slide from one of the early clinical trials that happened about, almost 10 years ago now, what they found was they could get some people dramatically better, but on average, the people who got active neurostimulators, which is green, didn't do any better than the people who got the device put in, but it wasn't turned on. It wasn't sending any electrical impulses to the brain. And the reason is because it's really hard to effectively tune it, and it's really hard to pick who's going to benefit from stimulation where. The reason for this, as I'll get into a second, is because these disorders can look the same on the outside but be really different under the hood. And this is where I'm going to end, is by talking about how we're trying to grapple with that problem, what we call heterogeneity. So, up to now, I've said words like depression, PTSD, addiction. Here's a problem. Those have really loose definitions. How do you define that someone has a major depressive disorder? Well, they feel sad or maybe irritable most of the time. They have an increased need for sleep, but they can also have severe insomnia and not be able to sleep at all. They could have no appetite and food tastes terrible, or they could have an increased appetite and be craving carbs all the time. And there's 9 criteria. You have to meet 5 of them. If you mix and match those, there's 500 different ways to be diagnosed with this same disorder. And the problem has been that we treat all those people with all those different symptom clusters as though they're the same disease, try and stimulate one little bitty piece of the brain and hope that works. And that doesn't work. That's like you're giving someone an antibiotic where you don't even know if they have an infection or not. And if they don't, an antibiotic's not gonna work for them. So, one of the things we're doing, and this is a big theme, honestly, throughout the U, is thinking about, can we redefine how we even describe mental illness, how we talk about what it is. And the idea is, rather than using these words like depression, like trauma, like addiction, which honestly, by the way, one of the things that this figure on the left is about is it's showing you the percentage of people in a large general clinical sample who meet each diagnosis. A lot of these things overlap so much that you can't actually tell in this language what it is that someone actually has. So the idea has been, what if we get more scientific in how we describe these? What if we don't talk about depression? What if we instead talk about, is the person emotionally numb and flattened? Or are they switching between crying and happy within 5 minutes? Are they what we would call emotionally labile or swingy? Are they able to change their mind in the face of new evidence? Or are they stuck? Are their thought patterns just trapped in a particular rigid, locked-in way that they can't get out of? And that one in particular, that idea of being rigid, of being stuck, is something that we've been spending a lot of time on because we think stuck is actually common to a lot of disorders. I've talked about the person with depression who has these automatic, why should I even try? It's never going to work out kind of thoughts. But a person with obsessive compulsive disorder has a stuck thought of something bad that's going to happen and a stuck behavior that they keep trying to do to prevent it. A person with trauma has something that they just cannot even approach because they're too scared of what might happen. And so we've started thinking about, could we directly target that? Could we directly target this idea of flexibility, or the technical term for it is something called cognitive control, and directly just change that? Build a treatment that we can actually measure when it's working and we can know when someone has the problem that it treats. I'm telling you about it because the answer is we can. We found out that by going back and looking at data from one of those old clinical trials, we showed that the people who were in that trial who got better, they actually got slightly more flexible on a laboratory test. Not much, just 5%, when their stimulators were on instead of off. And that this had nothing to do with how fast they could move or anything else. It was specific to their decision-making circuits. And in a paper that literally just came out 2 weeks ago, we showed that now we can use that to automatically tune what the stimulator's doing. That we can take someone who's undergone one of these surgeries, that we can have them do our laboratory measurement of how flexible their decision processes are right in this moment, and we can feed that through a control algorithm back into a stimulator and have it constantly change their settings till it finds what works and what drives them to that little 5 or 10% more flexible. When we do that, and that's going from those solid bars to those stripy bars, that can double the size of the effect. So now we have something that not only can we can actually define it mathematically, we can control it, we can use it to tune the stimulators. And this is where we think this might open up a whole new model of how we treat mental illnesses, where it becomes not about, oh, take this pill, have this stimulator, undergo this treatment, and your symptoms will go away. You won't have the bad feelings anymore. And moves more towards rehabilitative or assistive, where we can say, actually, what we're going to do is we're going to help you manage your own symptoms. We are going to give the power back to you and develop technologies that assist you in fighting the things that you've been trying to fight but just not been able to overcome on your own. And so that's what I want to leave you with this idea that there is a new paradigm emerging in this idea of targeted, specific treatment for mental illness, that it works, but we need to know who needs to get it and how to tune it for them, but that examples like the one I've just shown you, I think, are the way we can get there and are an example of how, by applying this kind of quantitative engineering-driven thinking, the topic of today's conference, we might be able to really open up new avenues in treatment. And with that, I know I'm over my time, so I'm going to end.
I'm sure Dr. Widge would entertain any questions if you have them.
I realize that was probably more than I should have done. Yes, ma'am.
What's the process like to figure out if their thinking has become more flexible?
That's the part we're working on right now. That's a great. So just to repeat it, especially for the onlines, she was asking, okay, that's great. So now you've got a tool for making someone more flexible. How do you figure out who's super inflexible? I mean, one answer is they'll tell you. That honestly, some people come into clinic and they say, I'm just sad all the time and that's my problem. But other people will say, I'm stuck, I'm trapped, I'm just locked into this thought pattern, and I know this isn't me, and I know I don't want to act like this, but I just can't seem to stop it when I'm in the moment. And so one way is they tell us. The other is that same. So to drill a bit deeper for a moment, the way we do this is there's what we would call a psychological task. There's stimuli coming at them on a computer. It's basically they're just judging numbers and identifying which ones are different from others being presented. But even that, and especially because we changed the decision rules on them fairly quickly, even that is enough to stress test those flexibility circuits. Just like if you're trying, you may or may not know this, but if you're trying to tell is someone at risk of a heart attack and which blood vessels that supply their heart have the problems, what you do is you put them on a treadmill and you make them run till they get chest pain, and then you can actually scan their heart and see, oh, right there, that bit of the heart muscle is not getting any oxygen. That's where the problem is. We think we could do the same. We could develop, and this is something in another breakout right now, my colleague Dr. Vinogradov is talking about how we're doing this. We think it's going to be possible to actually build stress tests for the brain that we can tell, oh, this person, when we have them play these standardized computer assessments, this person's like 30 or 50% worse than the average person of their age, gender, and educational background. Okay, that's a really specific, same way as, right? I mean, you're all familiar at this point with standardized testing. If you've got a big enough sample of people who filled in the same bubbles, you can say where someone is relative to the population. We think we could do that for these ideas like flexibility or emotional swinginess, or the tenet, I didn't talk about it, but another one we're really interested in is when you're faced with an uncertain situation, are you biased more towards avoiding danger or towards potentially capturing the opportunity? Do I have time for one more?
If there's one more question, yes.
So how would you apply, like, if all this works and it all, well, how would you apply with the tests that to a wide scale, like, application of this technology?
The gentleman's question is, how will we scale it up? Because not everyone can get brain surgery. Answer is, figure out what we're doing through invasive and being super precise, and then go non-invasive. I didn't have time to talk about it, but actually a lot of my clinical practice is in using high-power magnets that can directly hit small patches of brain from outside the skull and do what we call depolarizing them, activating them. Now, that's harder because you're basically taking a bank shot in order to try and hit your target as opposed to aiming straight at it. So you want to know the underlying principles of brain function really well. But that's exactly so the way we think about it is right now we're doing the invasive, the high-tech stuff, and once we get that to work, then we get to spend another 10 years or more figuring out how to do it all completely from outside the head, and that's when this becomes something that's accessible to all. All right. I should step back and
Let's thank
let
Dr.
Dr.
Widge for a great talk. Thank you.